Good afternoon, good evening even, everybody. Welcome to this webinar from the MSc programs at QMUL. And we're going to get started in a few minutes, just let a few people join in who are later comers, but we'd love you to say hi on the chat and let us know who you are, where you're joining us from. It's really nice to find out where people are in the country, in the world, and what your background is, because it gives us an idea of who we're talking to. Just to let you know, this is being hosted tonight by the MSc programs in emergency medicine at QMUL. So we're currently running two programs. One is in emergency and resuscitation medicine, and the other one is in tactical, military, austere and operational medicine. And there will be links put up at the end of the webinar, so you can go and find out more about these programs and to a previous recording from Tim and from Paul Rees about these programs as well. So it's great that a lot of our students, past and present, are joining us today. And we wanted to do this as a sort of autumn series to just keep a bit of CPD ticking over, to have an opportunity to bring in some great speakers such as Richard today and Malcolm Russell, who joined us a couple of weeks ago. And so just keep an eye on our Twitter feed and things for what's coming up as we carry on through into the autumn. It's now 6:36. I think we're going to crack on with tonight's webinar, and more people will join us possibly, and that's absolutely fine. We're really pleased tonight to welcome Professor Richard Lyon. He's an active consultant in emergency medicine based up at the Royal Infirmary in Edinburgh, and then, as your obvious choice would be, he's Associate Medical Director and works for the Air Ambulance in Kent, Surrey and Sussex. So his best friends have now become the EasyJet crew as he commutes between the two. He also holds a personal chair of pre-hospital emergency care at the University of Surrey. And he has a portfolio of research which is based around pre-hospital, with an extensive publication record in pre-hospital resuscitation, trauma care and emergency medicine. He's been honoured by the Queen for his services to emergency healthcare with an MBE, and he's a current member of the Resuscitation Council UK Executive Committee and author of several international guidelines. He completed his doctoral thesis on out-of-hospital cardiac arrest, a project that has developed into a national strategy for cardiac arrest in Scotland. And it is on this topic of out-of-hospital cardiac arrest that he's going to share his pearls of wisdom with us tonight. Welcome, Richard. Thank you for being here. I'll hand over to you.
Welcome indeed. Thank you so much, and thank you, Tim. Very kind of you to invite me to speak this evening, and obviously hugely tough act to follow. I've heard Malcolm's amazing talk from a couple of weeks ago and the outstanding case he presented. So let's just dive into hoping that the technology will do its thing and share some slides if these work. Someone can just give me a shout out and tell me they're working okay. Good. So thank you for dialing in this evening, folks. I promise not to keep you too long, and as Zibby said, please do jump in with a hand or a voice out if you want to ask a question. We're going to be focusing very much on how to survive out of hospital cardiac arrest. And as Libby mentioned, I'm very fortunate to work with the Air Ambulance in Kent, Surrey and Sussex. I get to see cardiac arrest on a very frequent basis. And I thought about how to address this topic. And, you know, when I have the privilege of flying out to these patients when they've often had a cardiac arrest, I was thinking, as Libby mentioned, it's actually just over 10 years since I did that doctoral thesis in cardiac arrest, and this picture was taken. And this was a picture of a man called John who was walking across the field, and he had a sudden arrest. And this is what we're going to focus on tonight. What has changed? What have I personally changed in my practice in the last few years? What's the update? What do you really need to know that's important if a patient like John is going to survive? Now, I know Malcolm talked about a immersion arrest. There's obviously trauma arrests. We're going to focus very much on the suspected cardiac cause, the unexpected event, the not end of life event, the pure resuscitation. And when I was thinking about this slide, I remember very clearly walking into one of my supervisor's offices and said, I want to do resuscitation research. And he said, what on earth do you want to do that for? They all die anyway, don't they? I think we have come an awful long way in terms of changing culture, because certainly a decade ago, there was this perception that they all do die. but we're actually not there yet. If you think about your own practice, how many times will you say, oh, they've been down an hour now, we're going to call it because, you know, that's time up. We'll come onto that at the end, but actually that hour window has suddenly got a lot bigger. But we really need to fight for our patients. And I would urge every single one of you listening in as we go through this evening, just to think about your system, where you work, and what small difference you can make. And that small little difference was something I coined from one of my great heroes, a guy called Peter Safar, one of the godfathers of resuscitation. And he coined the term resuscitationist. And when I was a junior doctor, I just thought it was insanely cool. And I wanted to be a resuscitationist, having absolutely no idea what it meant, but it just sounded awesome. And I was going to, you know, be one of them. And one of the things that Peter said was death is not a moment in time. It's actually a process which you go through. And I see that as a window of opportunity. And what we're going to focus on tonight is what can we do as pre-hospital providers to maximize John's chance of surviving that window of opportunity. So you're all super familiar with the chain of survival. We don't need to go through this. But you've got to get from one rung to the next seamlessly, effectively, without dropping the baton. So if you're Team GB, you die every time. Why? Because every Olympics, we drop the freaking baton. You need to think about your system, whether it's Shetland, Germany, London, all people I've seen dial in tonight, and think about, well, what does your chain of survival look like? Because it's going to be very, very different. Who's going to recognize the arrest on Shetland versus in the street in London? How are you going to get through these batons? And that's where you need to make a difference. And the other key thing that has changed in the last few years is that the chain of survival is not linear. It actually looks like this. Most of us on this call are sitting at the far right of this chain. You know, we do the sexy stuff, we do the RSI, we take people to intensive care. But actually, unless we're nailing that first rung, in many ways, we may as well not bother. And this is where we all have a role to play, as we have in Scotland, in lobbying governments and getting CPR into schools and all that kind of stuff. I like to think about it like this, that, you know, that bystander CPR bit is really, really crucial. And we know that more than ever these days. And I think we've all got a duty to engage in that. So I thought we'd just pick up where I kind of, you know, left off really in my MD days, which was some of the basic science, because it's worth reminding ourselves what happens to John's heart when he suddenly goes into VF and he collapses in that field. Well, this is what his heart looks like. So it's fibrillating away, it's flickering away. The right ventricle is on your left, obviously, if you look at it. Now the heart on the left is still fibrillating, and this is the same heart on the right that's left without any chest compressions for just a matter of a minute or so. We now understand that without CPR, this is what happens. The pressures in your heart start to equilibrate, which means your right ventricle balloons up, as it has on the right. The left ventricle is now so squashed, it doesn't take a rocket scientist to look at that picture on the right and say, well, yeah, that heart's never going to beat. You'll still see VF if you see the monitor. You can shock it to the blue in the face. It will not start because of pure mechanics. Another way to look at it is like this. This is a cross-sectional slice through a pig's heart, and you can see every 10 seconds as we go reading from left to right, you can see that cross-section, the moon-shaped right ventricle ballooning up and up and up, and that left ventricle getting squashed and squashed and squashed. Now, why is this important? Well, it's really important because chest compressions stop this happening. Chest compressions will keep your heart in that top left state. So when the shock is administered, you're actually hopefully going to achieve a mechanical ROSC, as not just an electrical one. You need that defibrillatory shock to actually restart the heart in terms of pumping again. So you all know that CPR is, of course, going to keep your brain alive, but actually it's important to keep your heart alive, and it's important that it will make your shocks more effective. So crudely, if John gets CPR, he's got a 1 in 5 chance of survival. If he doesn't, 1 in 20. very simple, and you all need to know that stat and be able to communicate that and influence that in your local communities, especially as this weekend is World Restart Heart Day coming up, thinking about where can you make a small difference. Now, some of the other basic science is quite striking. This is the chance of your shock working compared to the compression depth. So you can just see a small change, 2.5 centimeters of under compression can halve your chance of shock success. Now, this is important to us as providers. Why? Because we know that even after 6 months, the skill fade in CPR is really big. When was the last time you got on a mannequin with a CPR meter and just reminded yourself what it feels like, how deep to push, how fast to push? Very, very, very important. So every 6 months, make sure you're training your CPR again. Now, if you want a really good example of where this has been achieved, you must read this paper. This is what Denmark did. If you look at the red dot, their survival around about 2001 was, pretty poor, 3.5%. But then many of the regions we work, it's probably hovering around that. You can see survival to discharge, the yellow line, over the next 10 years steadily rose, and it exactly tracked the red to green dot, which was the bystander CPR rate. Still not great, just over 40%. In the UK, it's kind of 50-50. If you drop on the street when you go to work tomorrow, 50-50 whether someone's going to do CPR on you. So there's a lot of work to be done there compared to the 90% or so in Seattle. But you can see some of the great ideas they had around making CPR mandatory for a driver's license, or training school, or doing self-aid kits. It's really important. And I think lending our clinical weight to these programs is really important and makes them so much more compelling. Defibrillation. John's gone into VF. Clearly he needs defibrillators. What do we know about defibrillators? What stat do you need to know? Well, this is really straightforward and has not changed in the last 10 years or so. For every minute that your heart does not go defibrillated when you're in VF, your chances of survival are falling by 10%, 10%, 10%. So you can see that by the time you get to the 4 or 5 minute mark, your chances of going home again are already down at half. So you need to be defibrillated, and you need to be defibrillated very quickly. We've all seen the striking footage of Christian Eriksen having his cardiac arrest on the football field. He was defibrillated in about 3 minutes or so. You can see that's when outcomes are really good. To just reinforce that, this is your chances of survival when you look at whether you get CPR, whether an AED is used, etc. So you can see without intervention, you're down about 5%, UK average currently around 7%. Yeah, CPR is good, but you can see what happens when you get the defib brought to you very, very quickly. Now, this being so striking, if I said to you, in what proportion of cardiac arrest is an AED used? Have a think about that. It's actually not very much. It's about 2 or 3%. So we're going to a lot of effort. There's a lot of AEDs out there that absolutely will save your life. Look at that, 74% survival if you use it quickly, but they're only being used in 2 or 3% of cases. So there's a disconnect there. That's where it comes down to local geography. So why is that defib not being used? So you need to think about that, and your local area is going to be very different from a rural area in Scotland to the streets of London, where, for example, Good Sam app programs are absolutely making a difference. There's no question about that. And I would urge you all, if you're not already, obviously, to get on Good Sam, and it's doing some wonderful things. One of the things we're actually actively looking at the air ambulance to try and combat this delay or lack of use in AEDs is the use of drones. Now, you'll have seen and heard about drones before. So we'll play a little video, and I'll explain why I think actually this might be a good idea. So we've seen that the chance of survival isn't brilliant. In a typical scenario like this, someone witnesses it, 80% occur at home, And this is actually happening today in Sweden. This is not sci-fi, this is really happening. And the first thing that struck me is that, as you can see, the drone is actually flying in controlled airspace. So actually the air traffic guys know where it is, it's controlled, and it's a lot less risky that happening than flying it randomly. It's automated, but a pilot is following it just in case. And then the next bit was really interesting. The drone does not land, which I thought, that's another way we can de-riskify this. So it can reach the property, confirms the drop outside the house. And then essentially rapid long lines it, or whatever you want to call it, down onto the ground without risking hitting people, wires, etc., etc. And you can see how in such a situation, the difference between the 8-minute response that we have in the UK and the 3 or 4 can be a massive difference to getting that shock in early. Now, the results of this, there's 3 of these drones buzzing around Gothenburg today. The results of the initial pilot, I'm told, are very, very favorable. I'm really keen to see them coming out. My hunch is they're probably halving time to defibrillation. And we're actively looking at this for flying around the southeast, because the 2 things of flying in controlled airspace and not landing are a real game changer. And I think in the near future, we will see technology come on board. So what about us as pre-hospital providers? We rock up to John, you know, there's a crew that I've never met before. They've never met me before. They've got the whole why is the doctor here thing going on. How are we going to function together to try and save John's life? And this is really important to me, because I think we can all don the yellow jacket. We can all jump out the helicopter. We can all, you know, be the superhero. But actually being effective is really challenging, and it takes practice, a lot of practice, and a lot of feedback, and a lot of uncomfortable feedback, a lot of criticism. I think we're much better than we were 10 years ago at saying, actually, we can never do the perfect job. And recently I spent a bit of time with the McLaren Formula One team, and it's just amazing having these guys critique our resus practice. And one of the things they said, you know, someone's got to be in charge. They always have someone in charge, and they can change these tires in what, 1.2 seconds or something interesting. And they said, what is the difference between a team of experts and an expert team? And I would ask you guys the same question in your locality. How often do you train as a team with the people that you're going to be working with? And when I was in Norway a little while ago, I was absolutely struck by their resuscitation performance. They had a team leader who stood back. You can see the person doing CPR is only focused on the depth and the rate and the quality, and they changed every 2 minutes. They had 2 people on the airway, then 1 person on the defib. This was a very coordinated, slick operation. And actually, research has shown in the last 10 years that this absolutely does translate into improved outcomes from cardiac arrest. So just take a minute and think, how could I train in my team with my local crews, wherever you may work, to be more effective? Because training is absolutely critical if we're going to improve our resuscitation performance. Now, what else has changed? I arrived at John lying on the field, and the first thing I would do is don my superhero cape and grab my laryngoscope, because that's what we used to do, particularly as, you know, pre-hospital docs. The laryngoscope and the intubation was the way to go. And I'll put my hand up, I've completely changed my practice when it comes to airway management in cardiac arrest. And I think we've gone on a journey over the last few years, and I think intubation obviously has its place. Clearly now we are more cognizant of the fact it probably should be a 2-person technique. You need an assistant to set things up, and this is a pretty slick team. It involves technical skill, you got to lie on your belly and you got to get a view and you can try and get it in the right place, and your pal has to give you a bougie and the rest of it. And clearly this is taking time. Yeah, this patient might be on mechanical CPR, but if you don't have the luxury of that, you're going to have a big pause in your chest compressions, for example. And over the last few years, training in intubation has become increasingly difficult, particularly for paramedics. Now, it's important to remember a key Richardism. Under pressure, you don't suddenly rise to the occasion, but you will fall to the level of your training. You will fall to the level of your experience. I think this is particularly true for intubation. Unless we're doing this on a very regular basis, we probably shouldn't be doing it, because it will not go very well, it won't go slickly, and it will interrupt what we know is good science. So in the last few years, obviously iGels have come along, and it's important that you know a little bit about the science, because yeah, it's pretty clear that using the iGel is a one-man operation. It's, you know, technically not that difficult. You can put it in, fire and forget, don't need to get a view, and you know, away you go. It's a fraction of the time it's taken to you know, get oxygen into that patient than you saw with intubation. So the great supraglottic versus intubation debate. Well, if you haven't already, you absolutely must go and read the excellent paper from Jonathan Benger's group on the randomized trial Airways 2 of intubation first versus supraglottic first. Now I'm going to go off piece a little bit and just give you my Richard's take on this paper and how it's actually changed my practice. But please go and read it and critique it for yourself and draw your own conclusions. So you can see the headline here. There was no difference in ultimate survival. It's not ultimately going to make a difference according to this headline stat, whether we intubate John on the floor or whether we use an iGel. Both have similar modified Rankin scores, which is your outcome score. But if you look at the subgroups, there's a few interesting takeaways. So first of all, in the iGel group, they achieved effective ventilation faster. There was absolutely no difference in the incidence of aspiration regurgitation. If it had happened, probably happened already, you weren't more likely to get fish supper in your lungs if you used the supraglottic device. You were more likely to achieve ROSC if you had a supraglottic. And this was the bit that kind of got me. Now, I know you're not supposed to do this and you're not supposed to do the whole subgroup thing, but if you look at this group, the group that was randomized to intubation, but actually got supraglottic first, that to me made a lot of sense. So during resuscitation, we just focused on high quality resus, good CPR, put the iGel in, and then if we got ROSC, the intubation was delayed, because if you get a ROSC, that patient's probably going to go to ICU, aren't they? And they're going to need a tube. So actually just get on and do it at that point. And this is what I tend to do personally. I'll use a supraglottic if it's working well during resus, and I will intubate them immediately or very soon in the post-ROSC period. Is a thing to think about and thinking about your system. The chances of John having a cardiac cause for his arrest are pretty high, actually. About 70% we think are not necessarily a total coronary occlusion, but something going on in your coronary arteries that's tippled the heart into going VF and causing that collapse. And of course, the solution to that, as you well know, is, well, open up the artery again, and PCI is clearly the good way of doing it. And the challenge has always been, well, how do you do that without causing neurological injury, especially if the patient is in arrest? Because remember, most of these patients ultimately will die from hypoxic brain injury. Now, I wasn't going to go into the ICU management, but of course, we've had a lot of new evidence in the cooling versus normothermia space. And it seems to be that actually just maintaining normothermia is the way to go with these patients, which is useful because in the pre-hospital setting, probably don't need to worry too much around what to do with temperature. Now, if you get a ROSC, one of the big questions is where should you take them? what should you do? If you think, well, John's had a cardiac event, we should open up his coronary artery, we should take him to a cardiac center. And certainly in my service, that's what we have done for years and years and years. We've flown these patients a long way to somewhere where they can do PCI. Now, again, two homework reading lists are the Tomahawk trial and the COAC trial for you, both published in the New England Journal. And you can read them at your leisure. I'm not going to go into all the statistics, but what they showed was quite interesting, that if you had a non-STEMI post out of hospital cardiac arrest, there was no difference in outcome if you took that patient for a PCI straight away versus delaying it. And that's quite interesting, because clearly if they have a STEMI, the evidence stands, but there is probably not the evidence there to support immediate PCI in the post-arrest patients who have those, nondescript ischemic changes. Having said that, I think the evidence is increasing that taking these patients to cardiac centers, a bit like we take them to stroke centers, is useful, because of course, if you're in a cardiac center, you'll be looked after by people who are doing it on a regular basis, and there's always value in that. So I think we should absolutely be looking at cardiac centers. Now, what happens if John's heart just stays in VF? This is an animation of what your heart's doing. It's this random electrical activity. It's actually quite interesting. It's not actually random, believe it or not. One of my professors a long time ago, Colin Robertson, worked with some mathematicians to prove that VF is not random. Now, the cool thing about that is if you can hit VF at exactly the right spot, you could probably terminate it with about 5 joules, and you can absolutely store 5 joules in your iPhone if you had a little capacitor in there. So I'm hoping in my lifetime that we will have a device that means I can put my iPhone on someone's chest and shock them, but we're not quite there yet. But what I'd like you to do is have a think about the last time you saw someone who was in VF, and you shock them, and they're in VF, and you shock them, and they're in VF, and you give them some adrenaline, and you just kind of get round and round, you go through the motions. I think you need a plan for that. I think you need to think about, well, if I'm still in VF at 4 or 5 shocks, what am I going to do? There's no point in doing the same thing. So personally, what do? Well, I move the pads. I will probably get a set of new pads just to make sure they're new, and I'll move from the classic anterior chest position to an AP position, because sometimes just the vector of sending electricity through the heart, a bit like the iPhone analogy I just said, will be enough to terminate it. Personally, that's where I think double sequential defibrillation can sometimes work. So that whole, 2 defibs, mega shock at the same time, not sure personally that the evidence is really there, but what it does do is change the vector at which that electricity is flowing. Think about drugs. So I would certainly consider bicarb. I would certainly consider lignocaine in these patients, but have a plan for throwing the kitchen sink at John when he's in refractory VF. Now, very often they're in refractory VF because they have ongoing cardiac occlusion, for example. And I think this is the big change in the last few years that I personally think we will see come online, and is going to affect all of us. VA extracorporeal life support, or ECMO. So clearly John's heart needs fixed. He needs that PCI. Sometimes you need the PCI to get your heart going again. So what VA ECMO is, well, you can plumb in a hose pipe essentially into the venous system, into the femoral artery, femoral vein, take your blood out, which is unoxygenated, put it through a pump, which will also oxygenate it, which will also control the temperature to something resembling normothermia. And then you can plug oxygenated blood back into the femoral artery, thread that catheter up into the aorta and squirt oxygenated blood up into the head and down into the carotid arteries. Now, in the last few years, we've seen increasing evidence that this really does work. So if you look at the ARREST trial or the TRIA trial, again, please make a note of these and have a read of them at your leisure. You're seeing survival of 40, 50% in refractory VF patients who would essentially otherwise die. If you look at the ARREST trial, when those patients were just randomized to, normal care, ongoing shocks, ongoing normal resuscitation, as expected, about a 7% survival rate. Now, what has changed is taking these patients straight into a cath lab and just doing PCI on them probably doesn't work. So the reason it probably doesn't work is when you are in refractory VF and you are lucky enough to go on ECMO, you probably stay on ECMO for in the region of 1 or 2 days. Such is the period of time your heart needs to recover. So actually, I used to think, get them into the lab, open up the coronary artery, everything will be fixed, heart will work. It doesn't quite work like that. So you're better off pit stopping in the ED or wherever you happen to do ECMO. In this case, if you can do your ECMO in the PCI lab like they do in Denmark, so much the better, because you can do it all at the same time. That clearly requires some logistics, but that is the way to do it. Refractory VF into an ECMO thing, get the lines in, get them on pump, perfuse the heart, perfuse the brain, and then think about doing the PCI. And it works. The ARREST and the CHEER trial were both in hospital ECMO. So that was exactly that, getting them on mechanical CPR, and that is important. Personally, I think you should use mechanical CPR if you're going to move someone. Get them into hospital, get them on the ECMO, and these survival rates are achieved. Now the tech is there. The Maquet CardioHelp that you see in this picture is portable, and some of the centers of excellence, particularly somewhere like Paris, is doing this on the side of the road or the tube station or wherever you want to. So they've determined in their system the fastest way to do it is to take ECMO out to the patient. Now, Tim's team in London are looking at the same thing, the sub-30 trial, and they've absolutely managed to do it. They've got people on ECMO on the side of the road, on the streets of London. Clearly very labor intensive, and at the moment quite technical and quite expensive, but I think this is the direction of travel. It will become easier, the kit will become easier and simpler and cheaper, and I think more patients would benefit from this. So what kind of patients can we put on ECMO? Certainly, we're about to start a service up in Edinburgh. We've had a system whereby we can fly patients on the helicopter to King's to do this, but you have to be quite strict with your inclusion criteria. The arrest should be witnessed, it should be in a shockable rhythm. You need immediate bystander CPR and get them on mechanical CPR early. It should be relatively young with no comorbidities, and crucially, it needs to be on pump within about 90 minutes. This figure is a bit variable depending on which center you ask. Most of them are around the 90-minute mark. Clearly, the sooner the better. But I come back to where we started, that they've been in arrest for 60 minutes. Well, actually, if they've had good CPR for 60 minutes, you can absolutely get them on pump within 90. So we have another option for these patients. It's really important. So team, just to summarize, a few key pearls I think to think about. CPR is really, really important. And we have a role as clinicians to engage in our communities to push it, because unless we get the CPR rate way above the 50% it is now, we kind of won't bother. We need to get this AED rate up above 2-3%. We need to get these AEDs being used more regularly in the community, because that's what's going to be effective. Have a post-ROSC strategy for when you rock up as a provider. Personally, I've delayed my intubation and think about how you're going to keep people asleep. Look at your system, train as a team. If you're going to be effective, work as a team, train as a team. ECMO really does work. It's clearly not everywhere at the moment, but keep an eye on it, engage with your centers. If you're going to get patients onto ECMO, it's all down to us in the pre-hospital space, because we've got to get them there quickly. So you're going to have to train to be really slick, to do all of the things we need to do and do it even faster than we've ever done it before. Have a think now about the next patient you see in refractory VF, and don't just blindly continue, but have a strategy, have a plan, move those pads, use some different drugs, and try and do something different. And hopefully, if we all take a sec to think how we can make our own systems better, that marginal gains might just save a life like John's. So thanks very much for listening. Hopefully that was useful, and I'm very happy to take some questions.
Richard, thank you so much. Eloquent, concise and clear as always. I always learn, and I love hearing you speak.
My take-home points were exactly what you put up there, Richard, because I'm an educationalist at heart as well as an emergency physician. I was like, right, practice your CPR, practice your team training, practice your intubation, practice your pad positions, and we must never forget how important it is to practice and how it is to train and continue training throughout our careers. We're never good enough to stop and not keep practicing, and the best people are those who really do live and die by that, I believe. So your last slide was absolutely bang on in terms of that, which was fab.
Richard, we've got a couple of questions in the chat. So first question is from Solomon. You mentioned that you would use bicarbonate, and Solomon's asking, what are the circumstances in which you would use bicarbonate?
It's a great question, Solomon. Thanks for that. It's interesting. The guys in Seattle, Seattle Medic 1, that have one of the highest survival rates in the world for cardiac arrest, they all swear by bicarbonate. If you ever get the chance to visit Seattle or do one of Mickey Eisenberg's resuscitation academies, I would strongly recommend it. I think there's two really. So one is when there's very clear indication, so particularly your drug overdoses and you're following what you would do normally for a tricyclic overdose or something like that. That's a bit of a no-brainer. Personally, I start to think about it in prolonged arrest. So once you've been resuscitating for, and this is just anecdotal, but over about the 20-30 minute mark, you know that you're going to have a pretty acidemic state. You know that your heart is not going to like that very much. And if you are still in BF, if you're thinking about moving for ECMO, just correcting some of that, I think is probably a good thing. Again, that's reasonably anecdotal. There's not any strong evidence either way, but it would make sort of physiological sense. And the bottom line is you're unlikely to do any harm. So I think if you've got, a young, fit, it's goer, you're pushing out the time for resuscitation. And it's one of the things I have in my kitchen sink. So when I'm back up against the wall, I don't think that's the time to think about what should I put in the kitchen sink, because you want to chuck the kitchen sink at this person, you want to chuck it quick. So what I tend to do is kind of have my kitchen sink full of stuff, which in that case is bicarb, move the pads, put new pads on, and give them a bit of lignocaine. And then sometimes some magnesium as well.
With thanks. And the next question goes to ECMO. So you mentioned a 90-minute period to aim to be on and have flow. Question saying, look, if you've got ROSC periodically during your arrest, how does that alter? And how
That's a brilliant, it's a great question, John. I think if you have someone with signs of life, and especially that in and out of arrest, they're great candidates for ECMO, because you're probably in a low flow state, but when you have the ROSC, and your brain is probably pretty well perfused in those situations. So this is a bit of a mindset shift for us, because when you used to go to an arrest, you think, right, go in there and concentrate on good stuff. And this is where Gareth Clegg and Edinburgh's Perfect 10, I think, is very, very sensible. And what the Perfect 10 suggests is that when you get to an arrest, the first cycle, you think, right, should we be doing this at all? Is this really a resuscitation? You suddenly dig out the red form or something and you should stop, and that would be fine. The second cycle, you think about, well, just doing what you need to do, like getting the eye-gel in, getting IV access, thinking about, any drugs or whatever. The third cycle, have a good think about reversible causes. And then there's nothing else really to do. And at that point, I think if it's a goer and you've got ECMO, you've got to move. And you've got to move and resuscitate on the way. And this is a different mindset. So if you get ROSC on the way, well, that's brilliant. And if you get ROSC and it goes like, I think it was John suggested or Steve suggested, that's fine. We're moving towards ECMO. But what it means is at the 30-40 minute mark, we're in the ECMO room and not still on the living room floor. And from my experience, it's very interesting. You speak to the Danish swear not by this 90 minutes, but how long it takes to get the mechanical CPR on. And they've had some pretty positive outcomes with fairly prolonged resuscitation. And that's something you have to engage with your local ECMO team, because it's not yet commissioned for this work in England. So that just puts slightly different spin on it, and politics and money and all the rest of it. But yeah, just have a think about that. And I think if you're a critical care paramedic, or then we have 3IU, it's that decision making that we bring. So as Libby said, yeah, we've got to train and we've got to train well, but having clarity of thought and the ability to do good quality resus and think and make good clinical decisions is challenging. And that's where having a sort of step back team leader can be quite useful.
And as a centre, oh sorry, I was just going to say, Tim, as a centre that does have, we do put some of your KSS patients onto ECMO occasionally, and it's that real stepping back, making a really clear, careful decision before we do this. It's really, it's not rushed. It's not like, quick, they're in the door, do all of this. It's a really sort of time and considered thing, it feels like, which is important because it's a valuable resource as well, and it's quite a significant intervention.
Absolutely.
There's a lot of money in that. The next question comes up periodically, and I'm going to be very interested to hear what you say about this. Pre-hospital thrombolytics for patients with refractory VF. I mean, we've got that Hamburg study now from nigh on 20 years ago that suggested after 2 cycles thrombolytics had no benefit. But do you see a role for more targeted use? And I guess the next comment is, speaking to doctors and paramedics that were involved in that study, it seemed that many of them believed in thrombolytics. So the patients recruited to the study were probably the ones they thought were less likely to survive. I mean, I think it was an incredibly well conducted study, but actually if the troops on the street are selecting patients they think are going to do badly, then it's going to be very difficult to have a positive outcome. And I know in my pre-hospital arena, we often debate this. And what do you think? Do you see there's a role in the kitchen sink approach you disturbed? Should this be part of our VF treatment or VF storm treatment?
I think it's a brilliant question, Tim. And I think, and I stand to be corrected on this, but to my knowledge, there's not a really good pre-hospital cardiac arrest thrombolytic study using mechanical CPR. A lot of the early studies were using manual CPR, which for obvious reasons you would think, well, is the thrombolytic going where it needs to get to, and is it having time to work, and are you maintaining good perfusion? And I think, to me, one of the great unanswered questions is exactly that, Tim, and I don't know, it'd be good to do that trial. Absolutely, I have thrombolytics in the kitchen sink, and I think if I wouldn't say it was first line for me, but certainly those patients that have an ischemic event. So we've all seen those patients that have called 999 with chest pain. There's either a really good story, or even better, the ambulance team have got there, done a 12 lead and shown the STEMI, and then they've arrested, and then it's a bit of a no-brainer for me. I have to say, I'm not sure how effective they will be. One of the, we're thinking obviously about coronary thrombosis, but also pulmonary thrombosis. Sometimes, I don't know, when you see the pictures of the embolectomies that our cardiothoracic surgeons do, and you see the size of the clots that are coming out, and you think, goodness, is thrombolysis really going to gnaw their way through that? It's a difficult one, but I think on a case-by-case basis, would I not give thrombolysis to someone I really seriously thought was having an ischemic event? Yeah, of course I would, but I would be making sure they're on mechanical CPR, and I'd be leaving them on for a good length of time, and if possible, I'd be getting them, somewhere that can treat them. Now, this is really important, Tim, because of course what you don't want to do is give someone thrombolysis who would be a good ECMO candidate, because you're going to make your ECMO intensivist life an absolute nightmare if they've just been lysed. So given the choice, would I get them on ECMO? Yes. If you were in Shetland, because I know someone from Shetland is called in, would I thrombolyze them? Yeah, of course it would be in the kitchen sink armory, because ECMOs are not an option.
And are you all right for a couple more questions?
Yeah, absolutely. We're good for 10 minutes, or 10, 15 minutes.
So the next one, I'm going to expand the question. It is from Steve. He said, what about pre-hospital blood gas analysis? And I guess the next question is art lines. There's been lots of social media debate about art lines and using the diastolic on the art line to guide if we give adrenaline in smaller doses in some of the PEAs. And we certainly at EAAA, we looked at arterial gases, but we were looking at arterial gases to guide our ventilation. The resus guidelines stress don't ventilate them hard, slowly delivered breaths. You might wipe out the preload. But I guess by the time many of us arrive at arrest, particularly in HEMS teams, the patients are horribly acidotic, and ventilation may be a way we can control pH. And you've mentioned giving bicarb, and obviously a lot of that bicarb is going to be metabolized to CO2. So my personal take is I do on selected patients put in arterial lines, particularly recurrent PEA arrest, and I do think blood gas analysis is a much better way than end-tidal CO2 to guide ventilation. Do you have a view on that? Is that something you'd agree with, or? Yeah,
I'd absolutely agree with you, Tim, on that. I think certainly in the post-ROSC phase, especially when you've got a long transfer time and you've got, the bodies to do that without interrupting, all the basics, I would absolutely support that. And again, looking at our Scandinavian colleagues, putting in art lines is absolutely routine to them, and they're incredibly slick at it. I think interesting, you mentioned end-tidal, and I'm guessing the majority of people on this call probably won't be regularly putting in art lines, but they will be regularly doing CPR and regularly putting end-tidal on. And again, a very interesting study that came out of Oslo with just some very basic movements of your hand position when doing CPR can have an enormous difference in optimizing your end-tidal and therefore almost certainly your cardiac output in the resus state. So again, when you're next doing CPR, I challenge you to not just do it well, you've got to do it brilliantly. And it's very difficult to think about the rate, the depth, allowing for recoil, and then also looking at the end-tidal, and just even the movement of your hands by a centimeter or two can sometimes double the end-tidal that you're generating, because you're probably just creating a bit of better pump action. Again, I'll send the link to Libby so you can have a look at that paper as well. So yeah, before we look at art lines, let's just look at end-tidal and optimize that during resus, I would say as well. It's really important.
Indeed, and thank you. I've just reading Curtis's question. I'm going to read it aloud because I'm not sure it's a comment or question. I have to declare a conflict of interest that use of CPR feedback and early implementation of mechanical CPR instead of considering a prolonged arrest. And I think you've made it clear, like most people that work pre-hospital, you're a proponent of mechanical CPR because it's at least as equivalent. And I was surprised those trials didn't show an advantage, but we've had 3 good trials that didn't.
And it's a great question, Tim. And I think, obviously at that time I didn't deliberately go into all of the trials, but you're right, we're obviously all equivocal. I think mechanical CPR has a role, but it's very interesting if you deep dive into some of those trials, the time it took for the mechanical CPR to go on was really surprising. So not just the time in the arrest, so it going on at 20-25 minutes when probably futile, changing your strategy then anyway, but the actual interval to get it on. Now again, I think if you're going to do mechanical CPR, you've got 20 seconds tops, and coming back to Libby's point, you've got to practice and practice and practice so that you consistently can get on a Lucas or an autopulse in sub 20 seconds, and that really does take practice. And that's where I think if we were using that level of performance with mechanical CPR, we might show a difference, because just chucking mechanical CPR in the mix and not using it properly, I think is clearly going to lead to some weird and wonderful results. So I think it's a good point from Curtis that, what are we saying? Are we going to, focus on the basics, or just chuck the mechanical CPR in? Personally, I think this is where a different tiered level approach is useful. So I think for providers that see arrests on a fairly infrequent basis, like a paramedic in Edinburgh will see 3 or 4 arrests a year, that sort of numbers, they should focus on doing the basics really, really, really well. And that's that science we talked about. When you have your critical care paramedic or your HEMS team or someone who sees them a bit more regularly, has a bit more bandwidth, has that critical care decision making. They're the ones, I think, that then can make that decision about whether to put the mechanical CPR on because we're going to transport for ECMO, for example. If they're going to do it, they're going to do it slickly. Because if you kind of merge the two, the risk is you try and get mechanical CPR on in those crucial first few minutes, the basics don't happen well, and you lose the opportunity to get the ROSC early. So I think it's really important. I harp on again about looking at your own system and what resources you have and when they arrive and who's best to do what.
Richard, I'm going to ask you a question, if I may, and I know there's one more in the chat, but I'm looking at the time. So I spent the morning going over a systematic review of temperature management with many very prominent ILCOR authors on it, which was basically saying time to change the guidelines. There's been so much debate following TTM2 with proponents saying, look, we've still got to cool because it's avoiding a temperature. I heard a great talk by your colleague, Dr. Dunn, who was advocating that we still cooled based on evidence in the real world that when people stop cooling, temperatures rise and outcomes get worse. And I must say, I'm really torn. Where I'm working at the moment, a lot of the women are particularly conservative, and it is incredibly difficult to cool them in any sort of exposure. What's your thoughts? Are you still cooling? Are you? I know you said in your talk not pre-hospital, but in the ED when you've got ROSC, what's your thoughts?
Yeah, I'm. You know what, Tim? I'm going to bow to your and Mark and any intensivist greater judgment. I'm quite happy to say I'm not an intensivist. I don't look after these patients. It might, having done the TopCat trial, that was my original thesis. I think temperature is clearly important. There's no question about that. And for me, avoiding pyrexia. So what we did in TopCat is we measured these patients, and the vast majority of them get hot. They get pyrexial, and I've no doubt avoiding that is a good thing. And whether that's normothermia or mild hypothermia, I will absolutely bow. What I will say is I think, this is my personal view again, there is one bit that we just could maybe nail. And I was involved in a trial called the Princess trial, which was intranasal cooling. And you look at the animal evidence for that you put an animal into arrest. If you start cooling 2 or 3 minutes after ROSC, the survival is astounding. The neurological is astounding. And the reason that trial didn't work is we could not cool quick enough. A bit like mechanical CPR, it's the same story. We're not getting the snazzy tech on quick enough to show the impact. I do wonder whether if we were cooling, within 4, 5, 6 minutes, whether it could actually make a difference, because the science would really support that. A bit like Malcolm Russell, and you heard that amazing story from the child, how hypothermia must be playing a role in that child's survival, mustn't it? And if we can translate that into resus, it would be great. So more to be done in this space, Tim, is the bottom line. I'm sure it won't be the last we hear about hypothermia, but if I come in after arrest, I will entirely trust your judgment as to what temperature to put me on.
And very last question, which will be quick, because we're nearly at the hour mark, and I would this again comes up again and again, the argument of antiarrhythmics. Now, again, you've talked about your kitchen sink, and I think you mentioned lignocaine. And the question says lignocaine or amiodarone. I'm assuming you were saying lignocaine because you've already given amiodarone. Yeah, now, I know at Barts they say beta blockers, but the electrophysiologists at Barts, beta blockers is an answer for damn near anything. And I know most of my cardiology colleagues, beta blockers is their first drug for VT storm or recurrent VF. Do you use beta blockers? You mentioned lignocaine. Is that because it's something you carry or because you believe it's the best drug?
A bit of both, to be honest. I mean, again, we're in complete evidence-free zone here. You ask cardiologists, they think, esmolol's the best thing for this, and magnesium's the best thing, lignocaine. This is just an anecdotal sort of take on things. I think clearly, yes, you give your amio in line with guidelines, but I think then for me, do something else. Have a kitchen sink and then have the kitchen sink behind the kitchen sink, but try something. And I think further arrhythmics, personally, it's anecdotal that I've had good experience with lignocaine that's probably clouded my judgment. It's easily available because it's in things like, you know, the chest drain pouch, for example.
Yes.
You know, we don't often have some of these heavy duty things knocking around. So yeah, it's probably worth just having a plan as the bottom line. And again, I would bow to the greater knowledge of cardiologists on some of these things.
I suspect few in the world have got greater knowledge on this than you. Richard, you've given us a wonderfully entertaining hour. Thank you for the talk, and thank you for taking all those questions. I wish you a safe flight down to your air ambulance, and looking at the audience, I think there's a couple of people you might be seeing tomorrow. So thank you very much for all
you're
you've
very welcome,
done.
Tim. Thank you, Libby. Thanks everyone for dialing in. It's a pleasure joining you this evening.
Thank you, Richard. We really, really appreciate it. It's fantastic to have you here, and safe travels. And there's a few thanks come through on the messages. For anybody who's interested as well in the MSCs that we run, you can listen to Tim debating like this every week in his resuscitation module, and on it goes. It's a fount of knowledge and wonderful speakers from all over the world with lots of expertise, which is fantastic. So David's kindly put the links in there to the course pages, and there's also a overview presentation, which is the top one, which is recorded after a previous webinar. I put the links to most of the papers that Richard mentioned in his talk in the chat already, but I'll get any additional resources off him and make sure we post those. But we'll be sharing a recording of this and with all our other previous webinars, so you can share them with your friends and family and anybody else who's interested. And we thank you all for taking the time to join us here on this lovely Tuesday evening. Thank you, everybody.
Indeed, and I've just typed my email. If any of you have questions for the masters, please do drop them to me. I answer emails as quickly as I can. I will get back to you within 24 hours. If need be, we can arrange a telephone conversation. The masters is great fun. We've got wonderful people like Libby, and we have a talk from Richard indeed. And I think probably it turns out doctors that do end up as resuscitationists. Richard started his talk with that term, and many of us see that field of resuscitation as the most interesting and rewarding part of our life. So thank you so much for being here. Libby, thank you for organising this and all the work you've done. And the name you can see, David. David is the IT expert that in his own time joined us in these evenings and guides these talks and make sure they run smoothly. So I'll thank you. Libby, do you have any closing comments or anything else you'd like to add?
No, just to highlight that actually the MSc is open to doctors, nurses and paramedics, and one of the joys of it is the fact that it's interprofessional and it's international, so it's all delivered online. So it's not just for doctors who want to be resuscitationists, but we know from the chain of survival and those baton passing how important it is that we have everybody in the team fully trained up and fully aware, and with the professionalization of paramedics and ACCPs and all these roles, you know, we're getting some really great conversations, because as a hospital doctor, it's great for me to learn from the pre-hospital community and vice versa, and so we get that real sort of diversity of chat. So thank you all very much for being here tonight, and have a lovely evening. Thanks, Tim.
Thanks all. Have a great evening. Take care. Richard, safe travels, eh?
Thanks guys, see you later.